Hello and welcome to Globalsportscare. Today we've got another interesting subject speaking about plantar heel pain, and I have invited my friend and colleague Trevor Prior. Hi, Trevor.
Oh yeah, good to see you, Marcus.
So, Trevor, can you introduce yourself, what you're doing, and what your interests are?
Sure. So my name's Trevor Prior. I'm a consultant podiatric surgeon in London, and I work across the three sectors. So I'm a clinical lead for podiatric surgery and medicine at Homerton University Hospital in northeast London. I also work in private practice in London and on the Essex borders, and I'm a senior clinical lecturer at Queen Mary University London in the sports and exercise medicine department. So I have a number of interests, obviously foot surgery, in particular diabetic foot complications, but also I do a lot of sports injuries with gait analysis and detailed assessments and managing musculoskeletal pain.
Yeah, and we both met at Queen Mary, where I was lecturer as well. And now I came across this really interesting paper. Professor Dylan Morrissey and Christian Barton and yourself and a few others have actually published in the British Journal of Sports Medicine. And I asked you to go for us through the literature and what actually the current state is with treatment of plantar heel pain. And obviously this paper has another twist to it, being a systematic review, expert clinical reasoning, and also patient values. So thank you for that.
Yeah, no problems. Let me know when the share screen's up and we'll make a start.
It's up already. Thank you.
Okay, so this, as you mentioned, it was a multidisciplinary international collaboration of which I was one of the contributors. So why a best practice guide? Well, clinical practice is very variable and often not evidence-based. And whilst there's been an explosion of evidence, much of it's poor quality, and agreed guidelines are not well followed. So the best practice guide was built on a meta-analysis of the evidence, interviews with clinicians, and a patient questionnaire. The papers were assessed for quality with a sample size of 38 considered adequate. Efficacy was judged as primary if the intervention was compared to an appropriate control, or secondary when compared to a treatment that has proven efficacy. As is often the case with these papers, we started off with 11,769 papers, which were whittled down to 51 which were deemed suitable for analysis. Meta-analysis was undertaken with standard forest plots produced, with these two demonstrating the efficacy of custom orthoses on the top and shockwave therapy on the bottom. Efficacy was deemed positive if there was sufficient evidence and neutral if no evidence. The strength was high if there were multiple high-quality studies, moderate if one high-quality study, and limited if one high-quality study but with insufficient sample size. The evidence was also considered in the short, medium, and long term and color-coded according to the level of evidence. In this example, it demonstrates the benefit of custom orthoses in the short to medium term, so we can see green and light blue, but no evidence for the efficacy of prefabricated orthoses. Shockwave has the best evidence for efficacy in the short and long term, although this would suggest focused is better in the short term and radial in the long term. Dry needling has no efficacy, but both low dye taping and plantar fascia stretching do. I've divided the other interventions into those that have studies that were deemed suitable for analysis versus those that do not. For those with no efficacy, prefabricated orthoses are included, and we can discuss this further. And it may seem surprising that calf stretches are included, which certainly gives us food for thought. Some of the popular interventions simply have not been evaluated to sufficient standard, which includes the eccentric program, which I'm sure will be discussion later. Interviews were undertaken with 13 experts from 4 continents and 5 disciplines to develop a number of themes. These were combined with the evidence to form the basis of the guideline. The evidence and clinical reasoning were then presented to patients who undertook an online survey to explore their thoughts and experience to ensure these were included in the guideline. This allowed the development of the best practice guide based on a synthesis of the information and includes a guide to the duration and timing of interventions. As you'll see, there's a core approach throughout the course of treatment, with Shockwave and custom orthosis introduced if insufficient progression. Injection therapy remains an option, but is considered experimental due to the lack of evidence. The core approach centers around fascial stretching and taping, with a strong emphasis on education. It obviously needs to be adapted to the individual patient and covers load management, pain in particular, and understanding and monitoring of pain levels, related medical conditions such as BMI and footwear. The core approach with the introduction of Shockwave and custom orthoses are the key interventions, although it is acknowledged that injection therapy and surgery have a role. It is important to note that the interventions can be introduced earlier depending on the previous experience and level of pain. But further research is required to explore the role of off-the-shelf orthoses, injection therapy and surgery. Overriding all of this is importance placed on good patient education. But one of the things I'd like to mention is just what are we actually treating, because largely this is the treatments are based on a clinical diagnosis or ultrasound. But plantar heel pain involves a range of structures, and it's perhaps too simplistic to consider it to just be the fascia. Whilst ultrasound scans show thickening and are quick and easy to use, they lack the ability to adequately evaluate the varying structures. So we need to be able to evaluate the plantar fat pad, the fascia, intrinsic muscles and bone. In this particular instance, there is some mild thickening of the fascia and perhaps some intrinsic muscle edema deep to the fascia. By contrast, if we look at this case, there's superficial edema, thickening and internal derangement of the fascia and intrinsic muscle edema. This demonstrates further involvement and derangement of the fascia, with the cross-section showing the thickening, which is down here. I don't know if you can see my arrow, and a lot of intrinsic muscle edema. In this example, there's calcaneal bone edema, which in our experience often takes longer to settle. We see that on both those slides. In this instance, you can see the shape of the spurt is altered in this cross-section. So there's some plantar prominence laterally, which is directly impinging on the fascia. This has been present for years, so it may be possible to manage it conservatively, but will require orthoses with specific offload. Surgery may actually be a realistic option in this patient if it does not respond. In my practice, with severe cases or those not responding sufficiently, I tend to stage the condition with MRI. So time for discussion, thanks. Should I take that off share, Marcus?
Thank you, yeah.
If you'll let me do that. Up here, isn't it? There we go. Sorry, I'm working off two screens and it went on the other screen.
That's great.
There we go.
Now it's off. So thanks, Trevor. I think what is interesting about this paper is, how did it change your practice? How do you approach nowadays a patient which comes with referred plantar heel pain to you?
Funnily enough, it hasn't actually changed my practice much at all, other than sort of reinforcing it more than anything, because for a long time I've been telling my patients that the simple things are often the things that work, but they all need to be done together and for a sustained period of time. So too often you'll see someone who's maybe tried taping, that didn't work, so then they tried stretching, that didn't work, so then they tried something else, rather than putting it all together. So that would be the first thing. I think it has helped me sort of have more confidence that what I've been doing is supported by evidence, but also perhaps made me focus a little bit more on educating the patient. So I redid all my information sheets and stuff, and I have quite a lengthy one that really goes through plantar heel pain. And as you're aware, we've had at least one PhD student looking at plantar heel pain, and her papers are just all in publication at the moment, but they talk about some of the psychosocial factors and some of the contributing factors to heel pain, which is good to get patients to understand. And I really try and talk to them about load management, etc., which, you know, I know everybody does, but it's just bringing it all together in one kind of complete package.
Yeah. So, and before this video, we already discussed a little bit what was quite often used as the Rutlife protocol, and that seemed to be not being included in your study.
Well, as you see, the paper was reviewed, but it simply didn't meet the criteria for inclusion in the study because the evidence wasn't, the nature of the study wasn't sufficient. And although that showed some short-term benefits in terms of the outcome, you know, at this moment in time, of course, it doesn't mean that the eccentric program isn't valid. What it means is it doesn't have sufficient evidence to suggest it's valid. And the way I use the protocol is that if I have an athlete that's had plantar fasciitis and they've had a time off, then I may get them to do that eccentric program as part of a process to get the tissues used to be loading again, so that they're being stressed. So hopefully that will improve the tolerance rather than using it as a treatment per se.
Well, it's always several treatments you've been using anyhow with patients. Then the other interesting point is there's no mentioning of off-the-shelf orthoses, because quite a lot of countries you give just soft heel pads, and there seems to be no strong evidence for this either.
No, well, we probably ought to separate out soft heel pads from orthoses. So for me, an orthosis is something that's trying to significantly alter the way that the foot's loaded, and it can only do that by 2 or 3 mechanisms. It will be the shape of the device, the kind of stiffness of the device, and perhaps some of the friction components. And if you look at, it's fairly obvious when you talk to patients, etc., that cushioning, there was a section on it about focusing on footwear. So footwear needs to be supportive, be appropriately fitting, but also cushioning, because definitely that dampens the load. So I would put the heel pads into kind of that cushioning factor. Off-the-shelf orthoses have been used, but simply the efficacy for them it has not been demonstrated. And I think there's a reason for that, and that's because what often happens in a study is all the patients get given the same device, the same off-the-shelf device. But you only have to look at your patient's feet, and you know that you will see people that have a varying degree of arch height. They'll have a varying degree of motion within the foot and those individual joints within the foot. So the stiffness or the flexibility of the foot varies from individual to individual. So thinking that one off-the-shelf device will work for everyone is perhaps a little bit naive. And what was really interesting is that one of the papers that sort of swung it towards custom orthoses had actually detailed the criteria for each prescription. It was a paper by Chris Bishop in Australia. But all the prescriptions were the same in terms of the material used and the way that it was balanced. But the one thing that changed was the arch height of the device, and that's because it was made to a mold of the foot. So perhaps one of the secrets in that is how much arch mobility is and the height of the arch. And therefore, perhaps we should be trying to marry our off-the-shelf orthoses more specifically to the individual foot. And you'll know Professor Morrissey, Dylan, well, obviously, and it was Dylan that actually made me think of that, because we were discussing this, and he said, well, you do actually customize your off-the-shelf because you choose different ones for different patients. And that's just something I've practiced all the time, and I try and marry the off-the-shelf device to the patient. And so I wonder if there's some room for looking at that. And I think it's fair to say as well with custom orthoses that the papers that have demonstrated some efficacy, there's not really a standard prescription that you would give somebody for a custom device based on those papers. So there's clearly more work to be done.
Thank you. The other question is regarding the stretches. What do you suggest to your patients?
Well, I actually still give them calf stretches. I know the paper showed no efficacy, but if you think about the calf muscle and the anatomy, the calf goes into the Achilles, And actually, there is a link, there's a fascial link from the Achilles tendon through to the plantar fascia. So my feeling is that when you stretch the calf muscles, you're also getting a stretch on the fascia. I do get them to do a specific fascial stretch, which is based on the paper that demonstrated efficacy, which is a slightly strange one. So you dorsiflex the toes. So you're really putting the fascia on a stretch, and you actually grab the fat pad of the heel, the proximal fascia, and pull it in the opposite direction. But I still get my patients to perform calf stretches, and probably because one of the reasons is it's one of the single biggest things I find that adds a force onto the foot. So I think, there's that kind of risk and time benefit. So if you say that you're giving someone a couple of stretches to do on a morning or an evening, the chance of them having any harm is pretty small. And the time factor is they can brush their teeth or do whatever. As you go up through anything, if we go back to the eccentric program, whilst there could be efficacy for it with the right design program, it's just a little bit more time and effort for someone to do. So if you ask me which I was going to, I'll probably give someone a calf stretch before the eccentric program, unless they were returning to activity.
But the Rutlife program is also a bit of a stretch as well. So
granted, yeah.
And then coming back to what you pointed out is the educational component of your patients. Is there any focus you put on education, let's say weight management or load management, or?
Yeah, I definitely talk to them about load management. And, I sort of say to my patients, look, if I punched you on the arm and it was bruised and I sat there tapping it, 9,000 times a day, would you expect it to get any better? And they can usually relate to that. So, well, if you continue to load it, you're not giving it a chance to settle. So you've got to think about that. And I try and give them, people like simple criteria, don't they? So I sort of say to them that we don't really want your activity to be about more than about 2 or 3 out of 10. Some people might go to 4. We'd want it to settle within an hour of you stopping the exercise, and you get no reaction the next day. So you're no worse the next day. And if you're doing anything that's outside of that, then you're potentially aggravating the problem and you're not giving the treatments a chance to work. So I certainly do that. It's about just trying to make them, let's just turn that off. It's about trying to make them, Mrs. Prior, trying to contact me, trying to make them understand that. And then I do a big emphasis on footwear because most people's footwear is appalling. A lot of people like to wear these very soft cushion soles. I won't mention any names, but actually the shoes provide very little support, and therefore it doesn't really help from a foot function perspective. Slip-on shoes are probably a no-go because they're just tight, they're fairly unsupportive, and you often have to use your toes, which by just using your toes you can work the fascia. And we did a study at Homerton. 9 out of 10 of our patients and 9 out of 10 of our controls were in the wrong size shoes. So most people are in the wrong size shoes as well. So it's about trying to get them into the right shoes. And as soon as you can get them into a good supportive shoe with cushioning, so ideally a running shoe that fits well, that starts to make a difference. Now, if you want to put an insole in to the shoe, they've got more room, that's more likely to be efficacious, etc., etc. So it'll probably be around load management, making them understand what they need to do in order to try and get this better, and then having a real focus around footwear.
Great, thank you. And then obviously a big component of the paper was Shockwave. What do you say after this paper? You consider Shockwave a bit earlier in the disease, or?
Not necessarily. I don't think the papers made me want to go to it quicker. I mean, I know there's a different view in terms of the application of Shockwave, certainly in the UK, maybe compared to Europe, because I think in Europe it's used far more quickly. And I think what would be interesting is to have a paper that maybe looked at intervention times, So in the UK, Shockwave initially was guided by the NICE guidance, and the NICE guidance stated that you needed to have 3 months of failed conservative care. So from my perspective, I kind of still not quite work within that regime. If I take someone who comes in and they've just not really done anything, then I will put them onto the standard protocol, and my kind of usual review window would be round about 6 weeks. And then at 6 weeks, it would depend on their progression as to where I go next. I would not, in the vast majority of people, I'd expect them to be responding by then. And then we have a discussion about whether they just want to carry on with what they're doing because they're happy with it, or they want to do more. If they're being resistant, then that's when I would probably consider doing the MRI. So I can stage it. And part of that is to say, right, well, do you have bone edema? Because if you've got bone edema, I think Shockwave's good for that, but also it's going to take longer to settle down. So you need to really buy into this. And so somewhere between 6 and 12 weeks would be where I'd standardly do Shockwave, unless, of course, someone comes to me and they've been doing everything, right? Yeah. So then I'm going to be thinking about intervening sooner. So it's hard to be really dictatorial because it depends on where the individual patient is on that treatment pathway. And so we might introduce something. And I saw a patient only yesterday who's in so much pain that I might, injection therapy is considered from the paper experimental, but it certainly has a role to play. The thing is, when you use it early on in the treatment process, my experience and the evidence suggests that it works in the short term, but people often get a recurrence of symptoms. So I might be doing that to get them out of, so this particular patient, the degree of pain is in it, so there's the potential that the injection will dampen down that pain a percentage or even completely, so you can then put them on the rest of the treatment pathway.
And would you say the first choice of injection for you, and we've done this together, is autologous blood, or would you say PRP, or even high volume with a little bit of a steroid?
Well, I think I'd probably my first point with them would be a standard steroid injection under guidance, right? I mean, I think it might be different if you got a tear or something like that, because that's what the studies were showing. You mentioned the high volume injection, which we've certainly done, and the evidence isn't out there, but you'll be aware that we've had some quite amazing results with it. So it's definitely a study that needs to happen. And I still kind of a little bit mixed about PRP and stuff, because I think there are some papers that show it can be beneficial. They weren't a sufficient standard. They didn't have enough control, et cetera, to demonstrate the efficacy. And therefore, on a cost benefit basis, then it's a little bit harder to justify. And they might be the kinds of things we do when you've done all else. And the only other option would be surgery.
And you wouldn't have any concerns regarding a steroid causing the complete tear of the plantar fascia, because it would be your next treatment?
Well, exactly. So, I mean, you warn the patient about it. And what I say to them is, well, it's a complication, but if you were going to have surgery, you'd have the fascia cut. So you've effectively given yourself a surgical release. I mean, some of the surgeries will drill the calcaneus as well. So let's say, for instance, you knew you have bone edema. Then one of the options is to do some not subchondral, but some cortical drilling of the calcaneus, because you're trying to stimulate healing from that. But certainly there are percutaneous as well as endoscopic fascial releases. And if the fascia ruptures because of the injection, then you've kind of done your own surgical release.
Trevor, fascinating. Thank you very much for that. I think we've got a good overview, and thanks for this discussion. And and I'm going to put your webpage and where people can find you online on the blurb of this video.
Fantastic. Great talking to you, Marcus. Thanks.
Thank you.